Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovation to train a new generation of healthcare providers from a diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, Cost of Care and the ABIM Foundation created an online learning network to share ideas, educational materials, and share strategies in an open forum and discussion. Our goal is to discuss ways to start, implement, and sustain feasible innovations in teaching value at your institutions. The Teaching Value in Healthcare Learning Network has three major components. We'll have monthly webinars that are approximately 30 minutes long to hear on-the-ground work from national leaders and leaders in institutions throughout the country. We'll focus on how to adopt innovations at your institutions, and they'll be held on the third Thursday of every month. We'll also hold affinity groups, which are discussion groups online to get advice about how best to implement these new innovations and troubleshoot challenges. Thirdly, we'll have toolkits for educators, which is a space online on Google Shared Drive where you can download materials that will help you implement innovations that you hear. And finally, we'll have a section in publications and presentations. I am Reshma Gupta, the director of the Learning Network, and I'll be moderating today's webinar. Today, we are excited to have a resident leader in teaching value share with us her innovations. We are honored to have Corinna Zygourakis join us today. She is a neurosurgery resident and clinical fellow at the Center of Healthcare Value at the University of California, San Francisco. Her primary research interests are in reducing surgical costs, determining cost effectiveness in various neurosurgical procedures. She's a winner in this year's Teaching Value and Choosing Wisely Challenge for her innovative OR SCORE program, which stands for Surgical Cost Reduction Project to decrease operating room costs by providing surgeons with price transparency. We'd like to make the session as interactive as possible, and we ask you to submit questions online. If you click on the Google Plus icon in the top right of your screen, you'll find a Q&A icon where you can submit questions as we go along, and we look forward to having a great discussion. So Corinna, I'll actually let you take over and start describing your work.
Thank you so much, Reshma, for the opportunity to speak to you today and for inviting me. It's quite an honor. I'm really excited to tell you guys a little bit more about my project, whose goal is to decrease costs in the operating room by providing surgeons with price transparency. And just to give you kind of a little bit of background and why I started this project, obviously we all know that medical care is very expensive and surgical costs in particular are very high. And one of the things that was really striking to me as I started my residency training was how little surgeons actually know about the cost of the materials they use in the operating room. There was a really interesting study that came out a couple years ago where they surveyed orthopedic surgeons at academic centers, and they asked them to guess the price of implants that they used very commonly. So these included knee replacements, spinal screws, and they guessed anywhere from 1% to 25 times the actual cost of these items. So basically giving you a sense that surgeons have absolutely no clue how much things cost in the operating room. And it's very similar at UCSF as an academic center. I kind of describe it as this big black box. It's this for surgeons, the operating room is a wonderful place because you go in, you can have absolutely anything you want. It's like going to the grocery store. There are no price tags on anything, and you can buy whatever you want, and you don't pay the bill. So the goal of this project was basically to start putting price tags on things so that at least surgeons would have a sense of how much their supplies and how much their surgeries were costing. So what we did basically was develop these snapshots that compare surgeons to their peers in terms of the surgical time, and I'm just going to bring one of these up so that you can get an example. Sorry, 1 second, I'm just pulling up the screen share. So here's an example of a surgeon's snapshot for the resection of a meningioma, and you can see their surgical preparation time, their actual surgical time, and their supply costs. And we ended up showing them their baseline, which was from 2 years, from 2012 to 2014, and then have been showing them their costs every month this year, starting in January of 2015. And the project is rolling through December of 2015. So they can see how they compare both to themselves and to their peers, which is this line here. And then we also provide them with a breakdown of information about, we call these the bang for your buck items, which are the highest cost items times the number of times used. So for example, in this particular case, it's a craniotomy for meningioma. You can see that one of the very expensive items is a craniofacial cement that's used in closure. That costs nearly $2,000 and was used 4 times every single time that this procedure was performed in May. So we've been providing surgeons in neurosurgery, ENT, and orthopedic surgery, which happen to be some of our most expensive surgical departments, as well as one of the departments that I'm in, with these snapshots, and have been tracking their costs over this year. And we've seen some exciting preliminary trends downward, which is really great. But one of the things that I've been the most excited about is that it's really been kind of raising this discussion about cost consciousness that I at least had not seen in my department beforehand. At grand rounds, we have surgeons asking questions, oh, how much does that cost? And have many people from different departments come to me and said, oh, hey, you know, I was using this Botox filler, and I saw on my snapshot it's super expensive, and I got an advertisement from another company, and I saw that their filler was less expensive. So I checked, and we have it here, and I switched over to using that. So anecdotal examples of some of the changes that surgeons are making based on this.
Great. I mean, I think the work that you're doing is amazing, and the fact that you're spanning across multiple surgical subspecialties says a lot about kind of the culture and the buy-in there at UCSF. And I wanted to get a better idea, because I think, you know, listening to this, I'm wondering, if you're starting this new, how do you even get the information about costs? You know, what did you need to do to get this information from the institution to start with, and what kind of went into getting the buy-in to obtain those resources?
So I think we're really lucky because we have a program called Caring Wisely at UCSF that's run by Chris Moriades and Ralph Gonzalez. So basically, when my project ended up getting funded by this Caring Wisely grant, I was able to pull into all of their resources, including kind of data analysis, and Ralph and other members were great liaisons to the administration to kind of get support and buy-in from the administration as well, I think, which was crucial. So having that support structure with Caring Wisely in the form of people who have done similar projects before, like Chris, people who provided really important data analysis, and then people like Ralph who could really liaison with the administration and make sure we actually ended up getting a financial incentive that was sponsored by the CEO and the CMO of the hospital, and that came out in an email to the entire hospital, which I think was nice, sort of showing that this was something that the hospital truly cared about and was putting some money into. So I think all of those resources were really essential for actually putting this together and making this work.
Great. And, you know, I think when you think about programs across the country that don't yet maybe have the Caring Wisely program implemented, there's some additional barriers that might be there, but it sounds like there's definitely a way to obtain this data. And I think what's unique is how you presented it and how you actually did, you know, somewhat of an audit feedback to give you know, providers information with some frequency, which sounds like it was once a month. So I was hoping you could describe a little bit more about when you started this and you started providing these reports to the surgeons. What kind of reaction did you get from them? And also, what kind of involvement or effect do you think this had on the trainees in those departments?
So I'd say that the reaction from surgeons was, as you would expect, very mixed. Especially in certain disciplines, there were some people who came to me and they said, you know what, like, I don't really care about cost. My primary goal is to do the best surgery possible. And this is not something that matters to me. It doesn't matter if we have a financial incentive. You know, I don't think that, you know, I'm going to change my behavior based off of this information. And there are people who are very kind of open about that. There were other people who said, you know, well, why should I do this for the hospital to save them money? You know, what am I going to get out of it? And they thought that the financial incentive was very small, which in fact it was a pretty token incentive. So I did get those reactions, and then I got other reactions about people who said, this is, really exciting. This is obviously very important. We want to get more of this information. We don't have it. So I think it really spanned the spectrum. And I think that is not unexpected, because there are a lot of factors that influence what supplies a surgeon picks in the operating room. And those include everything like how they were trained, what they feel comfortable with, sometimes what data from the literature shows, although there's not a lot of great data for some of these supplies. And then there also, are economic and financial incentives, especially when you're getting in the area of like spinal implants and orthopedic implants. Reps are actually, for people who are watching this who are in the medical profession, in medicine and not in surgery, reps come into the operating room. You operate with them, every single day for 10 years. You develop personal relationships for them. So I think it's really important to kind of consider that there are a lot of factors that go into this, and I'm not necessarily expecting one snapshot to kind of go against all of those factors, but I think that in terms of raising awareness, it's certainly been helpful. And then for trainees, obviously they weren't a target of this particular intervention, but I did go to resident meetings for all the departments that were part of the intervention. ENT and ortho and neuro, and just tell the residents about what was going on. And at least for my department, it would be really nice to get feedback every once in a while. One of my co-residents would say, oh yeah, so-and-so didn't use cement. As you saw, cement is very expensive. Didn't use cement when he was closing his case yesterday, and he mentioned that he thought about you. So at least, getting that sort of buy-in from residents and knowing that it's going on.
Great. And, I think you mentioned this a couple times, but it sounds like a lot of the work that you did really started spurring more culture change and discussion through conferences or, in the OR or through another attending bringing up a new issue. So I'm wondering how these discussions started happening in terms of the drug reps. I think that's something that at least the, more folks on the medicine side don't come into contact with as often. And, if there's discussions that kind of trickle down to trainees about, in some ways how to deal with those pressures, or if those are things you're thinking about for future interventions at UCSF.
Well, I think the implant reps are obviously, they play a really important role in the operating room. A lot of times when you're using a new device, you're working with a scrub tech who hasn't used that. They certainly have a really important role in terms of instructing the scrub tech on how to use that device, in terms of helping when problems go awry. So they certainly do have a very important role. I guess for my own personal practice, I have kind of decided based off of this type of research to try to use all the different devices that I can in residency, so that I'll sort of feel empowered when I go to the next place, when I'm an attending, that I feel comfortable that I can use any type of implant. And there are other institutions that have already taken this a step further. So there are Kaiser and even some non-private places where they limit the number of vendors that come in. So that's something that's already been done at other institutions as a cost-saving maneuver. So I think there are a lot of interesting things in that area.
Right. And with this intervention, providing the audit, getting the information about what's being done, and then providing that information back to providers, was there any component of coaching, or was that something more informal that happened? If somebody was kind of significantly much more expensive or taking quite a bit more time preparing her in the operating room?
Yeah, so I did have a few individual meetings with some people who were very expensive and kind of prepared, this was just manually done, some additional analyses for them and trying to kind of coach them along. But I think at the end of the day, those were probably less effective than people who were necessarily either intrinsically motivated or whose departments placed a big emphasis on it. So I think one of the most important things is some departments, if it comes down from the chairman, like we're doing it, we're going to get that financial incentive, then all of a sudden surgeons are reaching out, and even from departments that weren't part of this, they said, oh, our chairman said we have to meet this financial incentive, can we get your data? So I think when it is more intrinsically motivated, it's a lot more powerful.
Great. And we just have a question that popped up from one of the viewers. So Chris says, hi, Corinna, great presentation. How important do you think it is that you were a neurosurgical resident leading this initiative rather than having someone from hospital management or someone potentially more senior in the department? You know, and I'll add to that as well as what advice do you have in that position for other trainees and other institutions to take something like this on?
Yeah, I mean, I think it's really important that it was coming from within because surgeons are very independent thinkers, and so that was kind of one of the things that motivated this approach for me as opposed to many other potential cost savings approaches that you could take in the operating room, and that this really still lets the power reside with the surgeons. They still get the opportunity to choose. It's not the administration coming down and saying, you know what, these screws are too expensive, we're not going to let you choose them. It's we're showing you your data, we're showing you how you can compare, and we're trying to give you some small carrots to improve your behavior in certain ways. And so I think that comes a lot better when it's coming from one of your own as opposed to being seen from someone from the outside, especially like CEO administrators. You know, obviously the more sort of senior surgeon support there is too, I think the more powerful it is. So there are, you know, some other departments, not my own, where there are more senior surgeons who are really invested in it, and I think that has led to some of the missing numbers that we're starting to see in like the ENT department. So
great. And one follow-up question that I have as well is, you know, hearing more about what challenges you faced. You discussed a little bit about some attendings being less open to this than others when you started, but thinking about, you know, other trainees across the country or even just other surgeons in general that are taking this on, what challenges could you foresee and what advice do you have about potentially dealing with those?
So I think, you know, the challenges are a lot of the things that I mentioned, the current climate, you know, whether sort of how the operating room is structured, what choices the surgeons have. There's some places where, like UCSF, where they can pick absolutely anything. There are other ones, even academic centers, where things are more narrowed down, so surgeons are kind of used to that, so it's created a different culture. So I think the OR culture is very important. And I guess the one piece of advice I would say, and maybe this is a little bit naive, and potentially this is coming from kind of the trainee perspective, is, you know, I do think that there are going to be people who have issues with this, and it's not going to be an easy road, but I think that most people realize that it is the future, and we do have to think about it. I think especially people who are kind of my level of training are going to be thinking about this more and more as they move into becoming attending surgeons. So I think, yeah, there are a lot of challenges, but it's something that we have to think about, and I think that it is more powerful if some of these solutions are coming from within, from the surgeons themselves, from the physicians themselves, as opposed to being enforced from externally. And that was kind of one of the big messages that I tried to get across. I tried to say, you know, if we don't self-regulate our costs, someone else is going to regulate them. So let's try to do that first.
Great. You know, and I've worked with a number of new leaders in different specialties, talking about kind of the hot topics when it comes to value within their specialty. And, you know, I've worked with folks in pediatrics who discuss prevention or potential cost saving over a patient's lifespan, or in psychiatry, it's often an issue of reducing expensive medication therapies, versus in, you know, internal medicine or emergency medicine, it's often reducing the cost of the diagnostics that we use. So when you think about the culture and kind of implementation within procedural fields, what do you think are kind of the most important or the most, maybe if not expensive, focusing on quality issues that come into light with procedural fields and in surgery?
So I think in surgery there are kind of two aspects of it. The first one is figuring out whether or not you should actually be doing the surgery in the first place. So taking a certain disease entity, and this is kind of where some of my peripheral work lies, in looking at different neurosurgical diseases and seeing what's the most cost-effective treatment for this, especially for ones that have multiple options. A malignant brain tumor obviously doesn't have a lot of options, but there are other things that we treat where you can treat them medically, you can treat them with radiosurgery. So I think the very first step is the surgical treatment cost-effective? Should we be doing it in the first place? And that, you know, basically needs some really careful studies using cost-effectiveness analysis techniques. And then the second one is, if we are going to be doing this surgery, we found it to be cost-effective, how can we decrease costs in the operating room. There obviously are a lot of similar supplies, and so I think trying to do things the cheapest possible while at the same time absolutely maintaining, the same quality of the surgery and the same patient care, which is very important. So no one is saying that we should be using faulty screws just because they're cheaper, but there are, just so you get a range. We have this same type of titanium screws for the spine, and they can range anywhere from like $650 to $1,000 just at our institution alone. So there is really a wide range of similar items. So those are really the two things that I think about in surgical fields.
Okay, great. And have you seen from after starting your, innovation in your project through Caring Wisely that it's led to other projects or kind of other trainees or other faculty taking on, similar types of issues within surgery or some of the other surgical departments?
Yeah, so actually I was just emailing right before we started with one of the urology residents, and he's also a fifth-year resident right now, a senior resident, and he is taking on a sort of a project that's really an extension of this. So he wants to take some of this cost data and actually create a training module for urology residents so that they can learn how to put together preference cards for the operating room, which are the cards that the nurses use to decide what supplies and what instruments to pick in the operating room. So I'm really excited about his project and kind of working with him and helping him really sort of based off of this data and kind of this momentum to create an educational module.
Great. And for other surgeons that might, be listening or folks that are in procedural fields, as far as you know, what resources do you feel like are available to you to learn more about this or to even collaborate together? It seems like within your own institution there's you're one of the people that folks will go to get advice to start this, but do you have any suggestions for other people in surgical fields?
That's a good question. I think a lot of this, well, maybe it's at least at our institution, some of this work started being done in some of the medical departments before it was done in the surgical department. So I definitely recommend reaching out to people. It doesn't matter if they're in completely disparate fields. People like Chris and Ralph have just been really instrumental in my thinking about how to design this project and how to really implement it. So I think I would definitely recommend reaching out to people in other areas in medicine who are doing similar things at your institution or even other institutions and just talking to them about how they did it, so that gives you a sense of what you can expect, what kind of challenges you can expect, what sorts of support and buy-in you need, not just from surgeon leaders but from administrative leaders, and that I guess would be my recommendation.
Great, and I think I echo the same as well, as that when you have a idea that you want to move forward, getting buy-in and reaching out to other people in the institution, it's going to lead you to success. So especially with this work, the health systems issues and getting cost information is probably the most important and similar across all specialties. So if you're collaborating with someone in a completely different department, it can help you move forward significantly than if you're still kind of fighting that battle on your own. But that's great. All right. And I think there's one more question that just came up. So what sort of resources do you need to provide support to people like yourself doing this type of work, especially if I'm a hospital administrator or department chair that wants to support you or another trainee in these efforts?
Mm-hmm. Well, I think obviously if you can create something similar to Caring Wisely, where you have people coming together from different fields, data analysis, statistics experts, people who have background research and like implementation science. I think all of those types of people are really useful. Just very practically providing some salary support during research year, helping out with a project manager or a data analyst. I think those are some of the key things.
Great. Corinna, you've done a great job describing your project, and I think all of us feel like your work is extremely innovative, and it's wonderful to have a trainee to come and explain the experience of getting such a large project off the ground. So I want to thank Corinna for joining us today and for all of you having a great discussion. Remember to check out the Tools for Educators link off the main page on the left side. That will link you to some of Corinna's materials needed to adapt these sessions at your institutions. And we also invite you to join us again next month on Thursday, August 20th, where we'll have Jessica Perla from IHI share their curricula on ICANN and the IHI Open School. Thank you so much, Corinna.